we stand on the cusp of a revolution in the way diabetes is cared for in New Zealand. With continuous glucose monitoring, will revolutionize the way in which persons with diabetes monitor their glucose levels to the same extent as in the 90s and 2000s, people moved away from urinary glucose monitoring to finger pricking, and now the next generation finger pricking to continuous glucose monitoring. And with automated insulin delivery, we will now have, for the first time, devices that mimic much of what a normal human pancreas will do. And these benefits initially will accrue to persons with type 1 diabetes and people with pancreatic insufficiency, but increasingly, and once again New Zealand is at the forefront of this, there is a role for these devices in type 2 diabetes as well. So by way of an overview, what I'm going to be talking about today is basically giving you a brief understanding of what continuous glucose monitoring involves, and a quick look at some of the various types that are out there. There is an array of choice. Then an overview of the various types of automated insulin delivery, a look at the special authority criteria, which is particularly important for our nurse practitioner, nurse specialist colleagues, and our primary care colleagues, because a lot of the persons with diabetes, upon hearing about this, will come to you, and you're now empowered to bring that technology to them. So an understanding of what persons with diabetes are eligible for, as well as a quick look at who benefits from AID, and a look at the future, including what potential role some of these technologies might have in type 2 diabetes. So one of the main reasons that you need to intensively monitor glucose levels in patients with type 1 and type 2 diabetes is landmark studies in the 1990s found that the more time you spend, and this was initially on the basis of people measuring their glucose levels using finger prick glucose 7 times a day in the diabetes control and complication trial, the more likely you were to have a normal HbA1c and the less likely you were to have complications. Self-monitoring of blood glucose was a paradigm shift from what was there before, but it had its limitations. And one of the limitations was that it really told you about what was going on at one point of time. So it was static information. It's information that stood still. It wasn't dynamic information. It didn't tell you whether your sugar was rising or falling. And if you looked at a whole day, you would need to finger prick quite a lot. And using a great amount of finger pricking would cause increased mental distress and more disengagement for persons with diabetes. And from a clinician or a clinician review point of view, work by Professor Benjamin Wheeler's team in Dunedin found that when they compared what was there in logbooks, which is still the predominant way that my clinic patients present their glucose information to me, and what was there on meter downloads, which is a relatively newer technology from like the mid-2010s onwards, there is up to like a 70% discordance. So 70% of the values that are there on the meter are not there on the logbook, and vice versa. And some of this is intentional, being afraid of what the health practitioner might say to you. And some of this is unintentional, just an error of omission. So continuous glucose monitoring is a technology whereby you monitor the glucose levels from the fluid around cells. As this diagram shows, if I can get to work, the sensor extracts glucose from the fluid around cells, and it transmits a signal to the transmitter, which via Bluetooth communicates to either a reading device, or more commonly these days, your mobile phone. There is a difference, or there's often what we call a lag or a delay between levels that you see in your blood glucose levels and levels that you see in interstitial glucose. And this delay can be between 4 to 6 minutes in a steady state, or even more, up to 10 minutes during exercise. Most of these devices can also communicate using Wi-Fi to the cloud, so you can have a secure way of storing your glucose information. These two devices form the core of one of my PhD research randomized controlled trials. So this is a type of do-it-yourself real-time continuous glucose monitor that hasn't been funded and will hopefully be phased out. This is a Meow Meow device, which is used essentially to put on another type of continuous glucose monitor sensor to basically enhance its recording and transmitting ability. And this is a Freestyle Libre, which is one of the devices that will be funded from next Tuesday. From an evolution point of view, we can see going forward from the 1980s, each successive generation, be it sort of glucose meters or first generation continuous glucose monitoring, second generation continuous glucose monitoring, has progressively gotten easier. Like, it's progressively gotten more and more non-invasive. The earlier versions of these devices, you would need to calibrate using finger prick glucose levels. The more recent versions, including several of the funded versions, don't need calibration. So you can actually rely on them in most cases to make clinically important decisions like how much insulin to take. They've become more cost-effective, more comfortable, and more convenient over time. Because we're dealing with information that's dynamic, that doesn't stand still, we're going to be shifting towards from looking at individual glucose levels at set points in time to ranges. So how much time or what proportion of the day you're spending within a target range becomes more important. So the key measurement or the key statistic in the years to come for both primary care, communicating between primary and secondary care in the era of continuous glucose monitoring is what is your time in range. And that in itself varies depending on your stage of life. So for most people with type 1 and type 2 diabetes, your target range, as defined by previous randomized controlled trials and by international consensus actually, will be between 3.9 to 10. And you should aim for best control to minimize your risk of complications, in most cases, to get a time in range of 70% or higher. And recognizing that the impact hypoglycemia or low sugar has, you should aim to get your time below range less than 4%. Now, recognizing that the impact of low sugars varies from time to time, and the impact of low sugars is more impactful in terms of cardiovascular risk or risk of sudden cardiac death when you're older. When you're older and have type 1 or type 2 diabetes, your recommended time and target range, or what we'll be happy with, basically reduces to about 50%. And the time in hypoglycemia, we become a lot more restrictive on that to reduce the risk to the individual. In contrast, in pregnancy, the target range actually narrows, 3.5 to 7.8. And the time that we expect you to be in target range for best results varies depending on whether you have pre-existing diabetes or whether you have gestational diabetes. Let's have a quick look at some of these technology types. The first is intermittent scan continuous glucose monitoring. This is the cheapest and perhaps the most basic type of continuous glucose monitoring. These devices stick underneath your arm. These sensors last for about 14 days. And in earlier versions of this, you would need to actuate or activate your glucose recording by scanning a reader or scanning a reader app on your phone. There is, with second generation devices of this company, known as Freestyle Libre 2, the option to use it very much like a continuous glucose monitor onto your phone. And what we've found is that the second generation device, which is being funded by Pharmac, is better than the first generation in terms of your HbA1c, your time in range, and your time in hypoglycemia. So just using these devices, even if you don't change any other thing, any other modality in your diabetes management, results in better control and less hypoglycemia complications. Because, of course, hypoglycemia used to be the main trade-off or the main risk when you intensified control in the era of self-monitoring of blood glucose. With how these devices have evolved, there's now a third generation device which is very much a continuous glucose monitor and integrates with insulin pumps to provide what's known as closed loop integration, which is effectively the pump and the continuous glucose monitor talking to each other, much in the way that a functional human pancreas would. The accuracy has increased over time. The sensor duration hasn't changed, and none of these devices require calibration. With real-time continuous glucose monitoring, how these differ from the previous devices is that you don't need to scan, and that you get information to your phone or recorder every 5 minutes. You get predictive alarms. So these devices can predict, especially the more novel devices, whether you're going to go low with about 20 minutes grace. So more than enough time if you're adhering to your alarms to actually go get something to treat the low. There's the option for remote monitoring, which has revolutionized the way young people, young adolescents in particular, experience the world with type 1 diabetes. Because they can, you can go to camps, sleepovers with a greater degree of security because your parent or caregiver, or even like the camp personnel with the appropriate permissions, can actually monitor your glucose levels and see, if you're at risk of going low or not. These devices have improved user satisfaction and reduced diabetes burden as well. And once you start to use this, you can act as a gateway to more advanced technology. There's a lot of information on this slide, but the key take-home messages in terms of trends are that the more modern devices, and in fact, all of these first 5 devices are funded in New Zealand, have pretty good accuracy. The warm-up time, the time to actually get them working after installation, has decreased to about 30 minutes. And they all have a pretty similar suite of alarms. And increasingly, almost all of them can be used for remote monitoring or following. So which continuous glucose monitor is right for you really depends on what you're wanting to use the device for. If you're not quite ready to take the plunge into automated insulin delivery, you can have a range of standalone devices which work with your injectable therapy, such as the Dexcom ONE+, the Freestyle Libre 2. However, if you're interested in using closed-loop devices, you should really be looking at the more high-end real-time continuous glucose monitor. And the funding is the same. The access is the same for both. In terms of the evidence, what the early evidence basically showed is that the real-time devices were better than self-monitoring of blood glucose levels. And then the later evidence has expanded the number of groups where benefit is shown to pregnant women, as well as a more wider subgroup where you had reduction in self-reported hypoglycemia worry and an improvement in HbA1c. What happens at a national level? Not only do you have an increased use and there's more awareness of hypoglycemia, but there's reduced hospitalization, both for DKA and severe hypoglycemia. So what we anticipate that we'll see is fewer people with type 1 diabetes ending up in hospital. What we've found is for real-time continuous glucose monitoring compared to intermittent scan glucose monitoring from a research colleague in the same institute at the University of Otago, is that the real-time continuous glucose monitors perform better in terms of time in range and HbA1c. What do patients experience? And this was part of the qualitative research that I did. When they go across to real-time continuous glucose monitoring from intermittent scan continuous glucose monitoring, you have an improved quality of life, reduced disease burden, you begin to trust the device more. However, If you have a device with a short sensor duration, or if you have trouble with phone connecting to your device, you can experience a bit of diabetes related distress, and you really need support from a practitioner point of view to help them through that. Briefly talking about automated insulin delivery, this has been a long journey as well. We're currently at step 4. We have devices where um, you can um, have pumps that communicate to uh, continuous glucose monitors, such that if your sugars are rising, they'll increase your background insulin and give corrections. If they're falling, they'll reduce your rate of insulin exposure. The only input you as the individual need to do is to tell the device when you're eating and how many grams of carbs you're eating. What we can look forward to in the future is a device where you only need to tell it that I'm eating a meal, and it will use AI basically to determine how much insulin to give you in a safe manner, and subtract, of course, the insulin on board. These devices come in various types, but they all have their individual idiosyncrasies in terms of what's needed to set up the various devices. Some require a wide range of information. More straightforward devices, such as the CAM APS, which will be available in the Ipsomed device, which is being funded, is total daily dose and body weight. What the clinician can adjust at a secondary care level also varies, from a wide range of things in the Medtronic devices to relatively small range of things like target glucose levels, carbohydrate ratios, and correction factors in the Ipsomed and Control IQ devices. The size of these devices is pretty similar. So in the past, like with insulin pumps, especially when they first started, they were the size of a backpack. Now they weigh between 80 to 100 grams. And the Ipsomed pump in particular, it's battery operated. The Control IQ device is rechargeable via USB. With diabetes technology, and this is a finding across ethnic minorities in the US and UK, as well as New Zealand, ethnic minorities tend to have less access, or access these devices less. We don't have a good idea on continuous glucose monitoring use in adults, because we don't have systematically collected data. But from Mercedes Burnside's work, we found that Maori and Pacific children were about 40% less likely to access continuous glucose monitors back when they were not funded. And from Dr. Ben Wheeler's work, we found that they were more likely to get pumps, these are adolescents, discontinued after the first year. This is despite having high known rates of complications and diabetic ketoacidosis rates in Maori and Pacific adults that have not changed. How do you decrease these barriers? And I think you need a variety of approaches. So at the practitioner level, you need sort of more visual and hands-on things, so workshops where you get to play with these devices, peer-to-peer support. Make technology part of the conversation. Certainly for type 1 diabetes, I do spend a proportion of my clinic talking about ways in which technology could assist them, whether with CGM alone, or whether if CGM users, whether they're ready to take the plunge into automated insulin delivery. Having patient or participant peer support is important. And from a society level, make diabetes tech more acceptable as well. You see sports people wearing continuous glucose monitors even without having diabetes. Nick Jonas from One Direction is a Dexcom user. The previous Olympic gold medalist had type 1 diabetes, and he used a CGM. So with more and more exposure to tech, will reduce the stigma, starting from celebrities, but working your way down into wider society as well. The nature of these devices will change. And so this CARES paradigm is a good framework to understand each new device. So when a new device, such as a new type of insulin pump, comes through, what you need to understand is how it calculates insulin delivery. How can the user adjust insulin delivery? Basically, what can we change and which things are fixed, which will vary from pump to pump. When does it revert to non-automated insulin delivery? In some cases, it's due to losing input from the continuous glucose monitor. In some cases, it's when it's not been touched or activated for 12 to 24 months. What are the key education points for breast practice, like bolusing for your meals, giving insulin for meals about 10 to 15 minutes beforehand, and how can you share your data? I'm quickly going to skip through the evidence, but basically what these trials have shown is that when you start from injectable therapy and you go to closed loop, you can get up to 36% improvement in time in range. And not only glucose outcome, but you can improve sleep outcomes as well. But in earlier calibration requiring devices, the work needed to calibrate meant that 1 in 3 adolescents would quit using the device. In terms of real-world studies, there's benefit in both the funded devices in older people in the Oracle trial, pregnant women in the recently published AI ADAPT trial, to a similar degree as non-pregnant individuals within the age of 20 to 40. So age and pregnancy status should be no barrier to accessing these devices. What do participants experience? And this is in a group of 16 pump users in a trial that we published in Frontiers. Using these automated insulin devices, especially with calibration-free sensors, enhanced quality of life. You had increased trust in the device and reduced disease burden. People spent less time thinking about their diabetes. So it means they could spend more time thinking about wider things in life. However, alarms, especially low and high glucose alarms, which need to be tailored to the individual, and sensor duration could be drawbacks, especially if you're using a device, as we were, the Medtronic device, that only had a 7-day sensor duration. These are a quick overview of the special authority criteria. So from October the 1st, next Tuesday, any individual who has type 1 diabetes, permanent neonatal diabetes, pancreatitis-related diabetes, or an atypical inherited form of diabetes, which is sort of maturity onset diabetes at the young, can access continuous glucose monitoring for a year and then have it renewed again if they're getting benefit after a year. There are some exceptional circumstances criteria there as well, which is basically if you've used a different device and are comfortable with it and it's too risky or too disruptive to your life to change. Who can benefit from AID? And this is based on research, including where the gaps in research are, as well as based on an equity framework where we're looking to use these technology tools and the improvements in glycemic outcomes they provide to reduce decades of disparity, Maori and Pacific individuals with type 1 diabetes. With pregnancy, it's more about getting as good glucose control as quickly as possible. And in adolescents, because they're a hard-to-engage group, you don't want to lose those 10 years of adolescence to poor control and have complications later. You want to give them a device that reduces their burden. And similarly, for severe complications, they can benefit from these devices. You might just need to do some tweaking. Who might find AID challenging? There will be a group of people that might not benefit from automated insulin delivery. And these are older adults, people who have arthritis, because a lot of these devices are touchscreen. So that's one of the more practical things you may need to think about. With visual impairment, although automated insulin delivery will be tricky, continuous glucose monitors can link in with devices like Siri. So there was an interesting small study in about 16 to 17 visually impaired people where just having a Dexcom device and having them ask, "Hey Siri, what's my blood sugar?" improved their time in range and HbA1c. There is a role for CGM in type 2 diabetes, and this is both at initial diagnosis to help them learn about their condition, but also when you're starting insulin to avoid hypo and hyperglycemia. And New Zealand has led the way with this, with the To Go CGM trial from Ben Wheeler's group, finding that with type 2 individuals, with type 2 diabetes on insulin, that their time in range improved, and this was mainly due to reducing hyperglycemia. And this has been brought out in meta-analysis, systematic reviews as well. What does the future hold? Decision support tools to get even more better control. And part of my PhD was an optimization study to get the best out of people already on AID. Fully closed loop devices, Faster acting insulin, so this is insulin that acts in about half the time that Novorapid does. Ultra long acting sensors using AI in CGM. And you have long-term implantable 6-month sensors now, which could be really useful for subsets of people, including elderly participants, needle-phobic individuals in whom changing sites and sensors every 10 to 14 days won't be practical. In conclusion, from October the 1st, a new world of diabetes technology awaits. Automated insulin delivery and continuous glucose monitoring in their own ways and also working together have the potential to improve glycemic control. Right now, because of the cost barrier and other barriers, few Maori and Pacific individuals with diabetes have used this technology, but we expect that to expand. There are also multiple patient groups with including those with type 2 diabetes, which is an area of active research where you could get some more benefit.